Welcome, everyone. I'm absolutely thrilled to guide you through this explainer today. Our goal here isn't just to memorize a laundry list of surgical techniques. It's to build a robust, clinical framework for refractive surgery. By the time we finish up, I want you to truly understand the physics, the diagnostics, and the surgical pathways. That way, you can not only crush your OCAP exams, but you can confidently explain these concepts to your own patients in the clinic.
Okay, let's dive into our roadmap. We're going to start with optics and refractive errors, move into corneal imaging and ectasias, tackle intraocular and corneal surgeries, and then wrap it all up with an OCAP rapid-fire review.
All right, Section 1, Optics and Refractive Errors.
To really grasp refractive surgery, you've absolutely got to understand vergence. So what is it? Vergence simply describes what light rays are doing in relation to each other. Are they spreading out? That's diverging. Are they coming together? Converging. Or maybe they're running perfectly parallel, which means the vergence is zero. In our normal anatomy, the cornea and the crystalline lens are essentially the biological tools the eye uses to perfectly converge these parallel rays right onto the fovea. Honestly, manipulating this convergence and divergence is the entire biological and surgical point of refractive correction. We're literally altering the eye's anatomy just to change how it bends those rays.
Now, I want you to lock in a mental model I like to call the error lens. This is a massive OCAP pearl, by the way. Think of a myopic eye, an eye that has way too much converging power for its length, as having a built-in plus error lens. The rays meet too early, right in the vitreous. Because of this excess convergence, a myope's far point is literally just out in front of their face. In contrast, the hyperopic eye just doesn't have enough converging power. The rays literally run out of eyeball before they can focus. So the hyperopic eye acts as if it's got a built-in minus error lens, pushing its theoretical far point way out behind the eye itself.
Let's take a quick pause for some board-style active recall. Think about the physics we just broke down. If a hyperopic eye essentially has a built-in minus error lens, what specific type of corrective lens are we going to need to offset this and actually achieve emetropia?
You guessed it, plus corrective lenses. By giving the hyperopic patient a plus lens, you are manually adding the convergence that their eye naturally lacks. You're perfectly offsetting that built-in minus error lens. If you understand the why here, you'll never have to blindly memorize which lens goes with which condition ever again.
Moving right along to Section 2, Corneal Imaging and Ectasias.
First up in our diagnostic toolkit is corneal topography. This setup uses a Placido disc, which is basically a set of illuminated concentric rings. Notice how those rings are literally projected right onto the tear film of the anterior cornea? A computer then analyzes the distances between these rings to map the surface curvature. If the cornea is warped, think of a misshapen funhouse mirror. Those reflected rings are going to look completely distorted. It's incredibly useful, but remember this crucial limitation. The Placido disc only maps the anterior surface. It gives us absolutely zero information about the posterior cornea or the overall tissue thickness.
So, to get the full 3D picture, we have to step up to corneal tomography, like a pentacam readout. This uses scanning slit or Scheimpflug imaging. Now here is a massive board trap. Relying solely on anterior topography to clear a patient for surgery. Don't do it. On one side of this scan, we're getting specific refractive data for both the anterior and, crucially, the posterior cornea. Posterior elevation is very often the earliest indicator of a hidden ectasia. We also get the pachymetry map, giving us precise corneal thickness. We absolutely need the whole shebang to properly screen for pathology.
And the main pathology we are relentlessly hunting for? Corneal ectasia. Ectasia is a non-inflammatory, progressive corneal thinning that leads to major warpage. Missing an ectasia preoperatively is a catastrophic clinical error. For your OCAPs, lock in these exact buzzwords. For keratoconus, you are looking for classic inferior steepening on the topography map. For pellucid marginal degeneration, look for the kissing doves pattern. Do not confuse regular astigmatism with these patterns. If you laser an eye with kissing doves, you will cause iatrogenic ectasia. It is an absolute contraindication to elective keratoablative procedures like LASIK. Seriously, you will ruin that eye.
All right, let's head into Section 3, Intraocular and Corneal Surgeries.
Let's evaluate our intraocular options. First, we have an isolated phakic IOL, and then you can beautifully see it vaulting right over the native lens in a living eye. Do not confuse a pseudophakic clear lens extraction with a phakic IOL.
In a pseudophakic procedure, we take out the native lens, which instantly costs the patient their ability to accommodate. But with a phakic IOL, we leave that native lens perfectly intact and just slip this corrective implant, essentially an intraocular contact lens, right in front of it, preserving their natural accommodation.
Moving to the surface, we've got our keratoablative procedures. In all of these, an excimer laser annihilates stromal tissue to reshape the central cornea and offset the patient's error lens. But here is the single most critical branch point, the factor that defines our entire surgical algorithm. How do we handle the epithelium to get down to that stroma? Whether we brush it aside, create a flap, or bypass it entirely, that's what determines if we're doing PRK, LASIK, or SMILE.
Let's contrast the big two, which brings us to a classic board question. In PRK, the epithelium is simply scraped or brushed right off. This makes the surgery pretty straightforward, but think about the pathophysiology. Destroying the basement membrane incites a massive wound healing response. That is exactly why PRK is associated with significant post-op pain and a much higher risk of vision-threatening haze. LASIK, on the other hand, creates a hinged flap in the stroma. We lift the flap, laser the bed, and lay the flap right back down. Because the LASIK flap beautifully bypasses all that major epithelial trauma, patients experience far less pain and a vastly reduced risk of haze.
Now, not all corneal procedures use lasers. Take limbal relaxing incisions, or LRIs. These are peripheral incisional procedures used specifically to offset astigmatism. Notice how the incisions are placed precisely on the steep meridian of the cornea. We typically perform LRIs at the time of cataract surgery. It helps smooth out the corneal curvature and gives the patient much better uncorrected vision post-op.
But whenever you make an incision, you've got to account for the physics of the cornea, specifically a super high-yield concept called the corneal coupling effect. Because the cornea is a closed dome, when you place an incision to flatten the steep meridian, you mechanically cause the meridian 90 degrees away to steepen. It's kind of like pushing down on one side of an inflated balloon. As that side flattens, the other side bulges up. You absolutely must account for this coupling when planning your nomograms.
Let's clearly categorize our tools for a few other specific conditions. For presbyopia, the main goal is improving near vision. We can use conductive keratopathy, where a thermal probe creates little scars that induce local steepening. Or we can implant a small aperture inlay in the stroma to create a pinhole effect. Conversely, for keratoconus, our goal isn't just refractive, it's structural integrity. Here is a massive OK pearl. We use corneal cross-linking, or CXL. This induces a chemical reaction that strengthens the physical bonds between the stromal fibrils, stabilizing the cornea and literally halting the disease progression.
Another incredible structural tool for keratoconus is intrastromal corneal ring segments. Let's orient ourselves here. Notice how the steep areas on the topography map are structurally flattened by the insertion of these physical plastic segments, which are visible in the slit lamp photos. The mechanics here are just fascinating. By bulking up the peripheral stroma, these PMMA segments act almost like a tent pole, pulling and mechanically flattening that bulging central cornea.
And that brings us to Section 4, the OCAP Rapid Fire Review.
All right, doctor, let's see what you've retained from our structural mechanics. Think back to those incisional surgeries. Which specific incisional keratorefractive surgery is considered totally obsolete in the US today, specifically because its radial cuts only flatten the central cornea, meaning it treats myopia, but is completely incapable of steepening the cornea to treat hyperopia?
The answer is radial keratotomy, or RK. Because you're making radial spoke-like incisions, you can only ever induce central flattening. This strict structural limitation, combined with long-term pathophysiology, a classic board question regarding its progressive hyperopic shift and fluctuating vision, by the way, is exactly why we just don't perform RK anymore.
Let's hit your top OCAP pearls before we wrap. First, arcuate keratotomy, or AK. This is placed on the steep meridian and is your absolute classic answer for post-penetrating keratoplasty astigmatism. Next, SMILE. Know that SMILE is unique because it uses a femtosecond laser to carve out an intrastromal lenticula. It is strictly non-ablative. Third, corneal power arithmetic. The anterior tear film provides a massive plus 49 diopters, while the posterior cornea minuses 6 diopters, leaving us with a net average central power of plus 43 diopters. And finally, remember your ectasia buzzwords. KCN equals inferior steepening. PMD equals kissing doves. I want to step back from the exam room for a second and leave you with this really profound clinical truth for when you're the attending. You can perform a literally flawless LASIK flap. You can perfectly calculate your nomograms. But current technology still requires compromises. Maybe your patient's going to have glare at night, or maybe they'll need reading glasses sooner than they thought. The true art of refractive surgery isn't just in your hands, it's in your communication. Establishing realistic and achievable expectations preoperatively is the absolute key to a successful outcome and a truly happy patient.
And this brings us to my final challenge for you. Tomorrow, when you're sitting in clinic and a myopic patient asks you why their glasses prescription is a negative number, I don't want you to just hand them a textbook definition. I want you to use the error lens framework we built today. Explain to them that their eye already has a built-in plus lens, and you're simply giving them a minus lens to balance the scale. If you can explain the physics that simply, you are well on your way to mastery. Thanks so much for learning with me today on this explainer.